Hello everyone! Today I'll be talking about a PhD project that I've recently finished, which investigated whether England should introduce a universal routine chickenpox vaccine. So you may have seen in the news recently that there is now a new recommendation that all children should be offered a chickenpox vaccine, and hopefully this presentation will explain some of the research that led to that decision. So the aim of this work was to investigate whether a two-dose chickenpox vaccine would be cost-effective, and in this presentation I will go through some background information around the topic and hopefully answer the following questions. Why has this not been done earlier? What has changed, and what did we do in this project that contributed? I'll start with a little bit of background. Chickenpox is caused by the varicella zoster virus, and around 97% of people will have chickenpox at some point in their life. Most children recover without any complications, but there are actually some serious complications that can arise. In terms of the burden of disease, there are around 600,000 cases of chickenpox a year, and around 6,000 of those require hospitalisation. A vaccine was approved for use in the 90s, and in spite of being introduced in several countries, has never been introduced in the UK. Chickenpox is also related to shingles. So following infection, the virus lies dormant, and reactivation of the virus in later life is known as shingles. This is most common in those over 50, but it can also happen in younger people. In 2013, a routine shingles vaccine was introduced for all those aged 70 to 80, but this programme is currently being amended. So why has this not been introduced sooner if so many other countries have done it? So in 1965, Professor Hope Simpson theorised that re-exposure to varicella zoster virus can boost immunity and therefore prevent reactivation, meaning if a chickenpox vaccine is introduced and the number of chickenpox cases is reduced, the number of cases of shingles could increase. So modelling studies have to consider this impact on shingles cases, but the duration of protection due to this boosting was unknown, so a large range of durations were used. Consequently, costs saved by reducing the number of chickenpox cases were outweighed by the cost associated with an increase in shingles cases. Modelling work in the early 2000s concluded this, and then in 2012 it was concluded that chickenpox vaccination may be cost effective after a long time period, but there is a risk of reduced population health. So what changes have occurred which means that this is now considered to be cost effective? The shingles vaccine introduction may mitigate any increase in shingles. Also, many countries have introduced this vaccine and haven't experienced as much of an increase in shingles as what previously expected. And finally, health consequences due to chickenpox have been found to be much worse than previously thought. I will now discuss what we did to contribute to this decision. We began by developing a dynamic model. So this picture is a visual representation of the model and shows how people move from being protected by maternal antibodies, so that's the M compartment, to being susceptible for chickenpox or varicella, to then being infected and then susceptible or infected with shingles. We also have compartments for those who are protected by boosting and those who are vaccinated. So any compartment that is prefixed by a V is a vaccinated compartment, and the two B compartments are the boosting compartments. So we show how people move between these compartments when there is or isn't a vaccination programme, and compare the number of varicella cases in each scenario. So what's different about this model to the previous ones, and why does this model yield different results? The answer is that this model has been informed from previous countries' experience. We used data from the USA to find out more about how long protection due to exogenous boosting lasts. We used our model to simulate the US vaccination program, which was introduced in 1995, to see which duration of exogenous boosting yielded a similar result. The increase that the US saw in their number of shingles cases was experienced both before and after the introduction of the chickenpox vaccine, but this increase plateaued after 20 years, so that's the pattern that we were looking for. This figure shows the increase in shingles from 1998 to 2019, and you can see that by 2014-2015, this is really starting to plateau off and the number of cases of shingles is actually started to reduce. So this is what we were looking for. This is, as I said, about 20 years after they introduced the varicella vaccine. So this plot shows the increase in shingles that we experienced from using our model for different durations of exogenous boosting. So we go from 1 year all the way up to 20 years of protection. It was concluded that 3 years of protection was the closest to the data that we had, but we also looked at 1 year duration and a 5-year duration just as an extra check. So this plot here shows the number of cases of chickenpox that we saw both before and after vaccination was introduced. So the red line is if we'd have carried on as we are now, just using a shingles vaccine, and as you can see, and as expected, there's no change to the number of chickenpox cases we see. However, if we do introduce a chickenpox vaccination, we experience a very vast and very quick decrease in the number of chickenpox cases. But what about what's going to happen to shingles? We do experience an increase in shingles, but this is much less than what's previously been modelled. So if we look at the shingles vaccination only, it decreases for a while and then plateaus off again. We reach what's a new equilibrium. If we introduce a chickenpox vaccine, there is a slight increase, and this lasts between 5 and 30 years, depending on the duration of protection that we use. The final stage of this project was a cost-effectiveness analysis. So the Department for Health and Social Care require all new medical interventions to be below a threshold price. So we calculated how much the vaccine must cost for the programme to be less than this threshold price. And these are the results that we got. So as we expected, if we have a lower duration of exogenous boosting and therefore a lower increase of shingles cases, we can pay a little bit more for the vaccine and it still be cost effective. If we have a greater increase in shingles cases with the 5-year duration of boosting, we have to pay less for the vaccine for it to remain cost effective. And over time, it gets more cost effective because that increase is less significant. So in conclusion, the introduction of a universal routine chickenpox vaccination will result in a large reduction of chickenpox cases. We are anticipating a small increase in shingles cases, and this will last between 5 and 30 years. Overall, the programme is cost effective at all different levels of exogenous boosting investigated, and actually over time becomes cost saving. The main driver of this cost effectiveness is the price of the vaccine, followed by varicella quali loss, so that is how bad it is for people who experience chickenpox. Thank you all so much for listening to this recorded presentation, and I'm sorry I'm not there to accept any questions.